Good afternoon. Welcome to the 121st webinar on prescribing NSAIDs safely. We did two of the series on psychotropics. We did one on antibiotic. And this is another drug which is prescribed by us without much thought. And our prescriptions are abused so much that we do not even realize. Leave aside what chemists give to the patient without our knowledge. What is the NSAID? It's an abbreviation for non-steroidal anti-inflammatory drugs. They're a class of medication to treat pain, fever, and other inflammatory processes because inflammation is what causes pain. And we all know that most commonly used and abused anti-inflammatory drug is a corticosteroid. So these are non-steroidal drugs. Steroids we know are most effective anti-inflammatory, but with serious adverse effects. You may say that I'm giving only for 5 days, but the patient will continue to take because it gives magical benefits. NSAIDs are FDA approved for use as antipyretic, that means to bring down fever, because inflammation also gives fever, control inflammation somewhere in the body, and also to relieve pain. They're useful for treating muscle pain. Unless you have diagnosed it's a specific muscle problem, muscle spasm, then you may give antispasmodics, which are synthetic opioids, which are better. Dysmenorrhea, arthritic conditions, pyrexia, that is fever, gout, migraines, and in certain acute trauma cases where patient has so much pain that you may be forced to give opioid, they may be used to spare opioids and give relief with NSAIDs. Let's look at a classification. Although we do not get involved into thinking of the type of the drug that we use. Hello, please keep quiet. Preeti, please mute everybody. Why do people talk here? Still the noise is coming. We normally think of the molecule that we are prescribing, or more often than not, we only remember the brand name. So the first is acetylated salicylates, that is aspirin. Non-acetylated salicylate, diflucinal salicylate, they are not available in India. Propionic acid, naproxen, ibuprofen. I don't know how many of you use naproxen. It's a wonderful NSAID. Acetic acid, diclofenac, indomethacin. Enolic acid, meloxicam or piroxicam. Anthranilic acid, mefenamic acid. And selective Cox2 inhibitors, celecoxib and etoricoxib. Now we come to the question of what is Cox2? And then lastly, naphthylamine, which is nebumeton. FDA approved non-selective NSAIDs. These are all the brand name, generic names. Diflunisal is not available in India. This video also will be available on YouTube for good. Then there are Cox2 selective NSAIDs and non-selective NSAIDs. These are Cox2 selective NSAIDs and these are non-selective. They work both on Cox1 and Cox2. We will see subsequently what is Cox1 and Cox2. Celecoxib, rofecoxib, this was withdrawn in 2004, and valdecoxib withdrawn in 2005. In America today, you get only celecoxib. In India, you also get etoricoxib. So what is the mechanism of action? Let's understand now Cox1 and Cox2. The main mechanism of action of NSAID is the inhibition of enzyme cyclogenase, which the abbreviation is COX. COX is required to convert arachidonic acid into thromboxane, which has a role in platelet adhesion, convert arachidonic acid to prostaglandins, which cause vasodilation and increase the temperature set point in the hypothalamus. The medicines have to inhibit this. The therapeutic effects of NSAIDs are attributed to blocking this conversion of arachidonic acid into thromboxane and into prostaglandins. There are two cyclogenase isoenzymes, Cox1 and Cox2. Cox1 is expressed in our body and it plays a major role in GI mucosa lining, kidney function, and platelet aggregation. If you see these three and relate these three with the common side effects of NSAIDs, which is GI bleeding, nephropathy, everybody knows NSAID nephropathy, and bleeding elsewhere also, avoiding platelet aggregation. So Cox1, if not inhibited, or if inhibited, you can get these problems. Cox2 is not expressed in the body. It is only expressed in the inflammatory stage. So Cox2 inhibitors, selective, will cause less of GI irritation, less of bleeding, and less of nephropathy chances. Most of the NSAIDs we use are non-selective. They inhibit both Cox1 and Cox2. Now, we know that Cox1 plays a role in maintaining the integrity of GI mucosa, kidney function, as well as platelet aggregation. Commonest adverse effect of non-selective NSAIDs, which inhibit Cox1 also, is on GI mucosa, on kidney, and bleeding, because I am taking away the protection that Cox1 gives. However, Cox2 selective NSAIDs like celecoxib only target Cox2 and therefore have a different side effect profile, not the GI tract, not the kidney, and not bleeding. More importantly, because Cox2 is mainly involved in inflammation, because Cox2 is only expressed in that, it is not expressed in GI mucosa, kidney, and platelet aggregation. Cox2 selective NSAID should provide good anti-inflammatory relief without compromising the GI mucosa, renal function, and bleeding issues. So I hope now it is clear that using a Cox2 inhibitor for prolonged use is safer than using non-selective NSAIDs. Okay, this is the same slide that has come. So we know now NSAIDs have three common effects and why they have: GI mucosa, kidney, and bleeding disorders. Gastric adverse effects are likely due to inhibition of Cox1, prevents the creation of prostaglandins that protect the gastric mucosa. Gastric mucosa remains unprotected and you have GI symptoms with NSAIDs. The damage is more likely in a patient that has a prior history of ulcers. Now, although literature talks of ulcer, we know that due to the massive use of ranitidine and similar products and PPI, proton pump inhibitors, ulcers are a thing of the past, but people still have a lot of GERD, a lot of acidity because the lifestyle is bad. So if a patient has a previous history of severe acidity or bad GERD, then the gastric adverse effects are likely to be much more. Since it is Cox1 specific, the use of Cox2 selective NSAID is a lower risk alternative. I'm not saying it is 100% safe. The risk is lower. Renal effects are because both Cox1 and Cox2 facilitate the production of prostaglandin, which play a role in kidney circulation, maintaining the integrity of the kidney circulation. In a patient with normal renal function, inhibition of prostaglandin synthesis does not pose a renal problem, not large problem. So if a patient has normal creatinine, I'm not worried in giving that patient an NSAID, fearing kidney complication. But if a patient has slightest nephropathy, suppose creatinine normal range is up to 1.4 and patient is 1.5, I will stay away from giving any NSAID, either non-selective or selective. In a patient with renal dysfunction, prostaglandins play a very major role, and then you can have problems by using NSAIDs. What are the complications that occur? A patient may have acute renal dysfunction. Since our kidney maintains all our fluid and electrolytes, you will have major fluid and electrolyte disturbances, renal papillary necrosis, maybe nephrotic syndrome, interstitial nephritis, depending on what was the kidney status before and how long the drugs were given. Cardiovascular effect. NSAIDs do give adverse effects in the heart and blood vessels also, which could be a myocardial infarction, a thromboembolic event, a clot in the cerebral sinuses, maybe a DVT, and in patients who are susceptible, even atrial fibrillation. Diclofenac seems to be the NSAID with the highest reported increase in adverse cardiovascular events. So when you're writing diclofenac to a patient, please get history of any cardiovascular problems in the patient. Then liver. Since most of the drugs are metabolized in the liver first pass system, abuse of NSAIDs or giving NSAIDs in a patient who has liver problem can be counterproductive. And it could be, if the patient is chronic liver disease, even 1 or 2 day diclofenac or one injection of diclofenac can put that patient into hepatic coma and maybe death. Although they're less common, but in a patient with susceptible liver, compromised liver, they have problem. So they either give raised amino acid levels, aminotransferase, SGOT, SGPT will rise. That is not common, but then I have seen patients of cirrhosis of liver actually dying by use of NSAIDs. Again, diclofenac has a major issue in already hepatocompromised patients. So today, many of us are using diclofenac without a second thought. Please pay attention. At least take patient's history beforehand. I have seen in certain nursing homes, patients of acute hepatitis are given diclofenac injections. Hematologic adverse effects are possible, probably with non-selective NSAIDs, which inhibit both Cox1 and Cox2 due to the antiplatelet activity. This effect only poses a problem if the patient has a history of GI ulcers, like hemophilia condition, thrombocytopenia, or von Willebrand. So please do not use diclofenac or any other NSAID in a patient with dengue, especially with thrombocytopenia. You may cause a crisis. Other minor effects include anaphylactic. We had patients with a single oral tablet of diclofenac or ibuprofen or piroxicam going into anaphylaxis. So always be prepared when you are giving an injection, especially. Of course, tablet also can cause. Everybody knows that aspirin exacerbates respiratory disease, causes asthma-like features. NSAIDs with a high GI toxicity are piroxicam, ketoprofen, and ketorolac should be avoided. The gastric damage can be reduced by associating NSAIDs with misoprostol, which is a prostaglandin itself, or proton pump inhibitors, which now has become a common prescription of every specialist. But remember now, studies have shown that abuse of PPIs is leading to renal damage as well as early osteoporosis. So I would say if a patient does not have a history of acidity, GERD or ulcer, you may give a NSAID which is gastroprotective or entry-coated and ask them to be taken after meal and not on empty stomach. If no GI risk factors are present, non-selective NSAIDs are preferred, not etocoxib or celecoxib. If one or more GI factors are present, coxib should be used, or NSAID plus PPI. If you're using coxib, you need not use PPI with that. Patients with low cardiovascular risk, no hypertension, no diabetes, no heart disease, can be administered either a non-selective NSAID, which inhibit both Cox1 and Cox2, or a coxib. The choice depends on the GI risk. In patients with intermediate severe risk, they may not have had a heart disease, but they have hypertension, they have diabetes, and they have dyslipidemia. This will be called intermediate risk. The choice should be ibuprofen or naproxen plus PPI. The patient with high CV risk, the choice is naproxen with PPI or aspirin given 2 hours. If you are giving aspirin, patient is taking aspirin, then please make sure aspirin and naproxen, there is a gap. One thing which most of us do not do is when you're giving a patient NSAID, you don't ask whether the patient is on aspirin 75 milligram as a cardioprotective. The patient is taking, then make sure there's a gap of 2 hours between aspirin and the NSAID that you prescribe. NSAID contraindication is very specific hypersensitivity to that NSAID patient has taken before, had allergic reaction, or with aspirin they have had a reaction in past. We will not give NSAID. We will not say let us try one more time, because we know that every time the allergic reaction will get worse till one day the patient may get anaphylaxis. Do not give NSAIDs to patients who have undergone CABG. Don't give NSAIDs in 3rd trimester of pregnancy. How do you monitor? This is long-term NSAID. This is not short-term NSAIDs of 5 or 10 days. This is chronic use of NSAID when you give in certain conditions. I'll talk of these conditions in detail subsequently. Recommended monitoring includes CBC, creatinine, and a liver panel, or maybe just an SGPT. These recommendations come from American College of Rheumatology. If you're using NSAIDs for rheumatoid arthritis in addition to disease-modifying drugs, then you have to monitor these. Prolonged use of NSAIDs in rheumatoid arthritis with patient having no kidney problem, no liver problem, no heart problem, no risk of GI, you have to still monitor CBC, creatinine, and SGPT. Monitoring is less common in patients not considered high risk. Like if you have a young patient of 30 who doesn't have any other disease, you may not monitor monthly, you may do it every 3 months or so. However, NSAIDs are either contraindicated or their use requires monitoring regularly in patients with already liver and kidney problems, because they can get worse overnight also. Again, toxicity, overuse of NSAIDs. You know, today you must have heard of a lot of patients who take paracetamol 650. I won't take the brand name here. Every 2 hours, thinking the fever should be kept down. People, if you write a ibuprofen 400 3 times, they will take it 5 times because it was giving relief, but in 2 hours the pain came back. So that can lead to toxicity of NSAIDs. It can manifest either as GI bleeding, high blood pressure, liver damage, or kidney damage. Typically, acute NSAID overdose is asymptomatic and hence patient does not report to you. They keep taking and there are negligible GI symptoms. However, other symptoms of toxicity may be metabolic acidosis, so patient will start feeling breathless. Like in salicylate intoxication, you get breathlessness. Patient may go into coma. Patient may get seizures, or patient may get acute renal failure. So if you are, the time has come that of our every prescription should say, please dispense only once and only the amount described. Then we know that NSAIDs inhibit Cox1, which is protecting the mucosa, and then decrease gastric mucosa production. Kidney toxicity, I have said enough times. with NSAIDs because they reduce prostaglandin level and they can cause major problems. Lastly, neurological toxicity. We never thought that NSAIDs work on the brain, but an toxicity, overdose, or a patient even with normal dose who's got a liver or kidney problem and is not metabolizing or not excreting properly, they may land up with drowsiness, confusion, nystagmus, blurred vision, diplopia, headache, tinnitus. So anything abnormal, take it with seriousness. Don't think it is weakness. Okay, there's the same slide come in. These few slides are very important because most of our patients are taking other medicines regularly and we do not bother about the drug interaction. In patients who are normotensive or untreated hypertensive patient, NSAIDs have a weak effect on blood pressure. So if a patient is normotensive or is not taking antihypertensives, NSAIDs won't affect the blood pressure. The addition of NSAID to an antihypertensive could reduce the efficacy of antihypertensive with a very poor control of blood pressure. So if you have a patient who's on telmisartan or olmesartan, a particular dose, and is maintaining 130/80, you give some NSAID, the effect of antihypertensive will go down, the BP may shoot up. Several classes of antihypertensives are more prone to suffer this interaction: ACE inhibitors, angiotensin receptor blockers, diuretics, and beta blockers. So roughly 4 categories which are most commonly used. Calcium channel blockers and centrally acting sympatholytic drugs like clonidine, methyl dopa are not affected, but we hardly use clonidine nowadays because of the fear of postural hypertension. Methyl dopa we use only in pregnancy. So these 4 groups are almost 90% of patients get one of the 4 group drugs. Elderly patients, 65 plus, 70 plus, on antihypertensives will have a major change in blood pressure when NSAIDs are combined. When combined with blood thinners, if the patient is on warfarin, NSAIDs increase the risk of bleeding. There was no studies available with newer oral anticoagulants, but with warfarin, it increases the risk, even with heparin. They can cause kidney failure when they're combined with ACE inhibitors and diuretics. So chlorothiazide, indapamide, and ACE inhibitors, be very careful while giving a long-term anti-inflammatory or NSAID. They oppose the effect of medicines for heart failure, as they oppose the effect of antihypertensives. Even heart failure medication, ACE inhibitors, beta blockers, and diuretics, the effect is blocked and the patient may go into a failure. Going a higher BP is still acceptable, but when a control of heart failure goes down, then the patient may actually lose life. Also considering that another diuretic, spironolactone, may increase the risk of GI bleeding, patient should be informed that long-term use of NSAID could increase the probability of GI adverse effects. In conclusion, hypertensive patients under treatment with ACE inhibitors or hydrochlorothiazide should avoid chronic use of NSAIDs. Avoidance of chronic use of NSAID in patients under treatment with cardioprotective aspirin 75 to 150 milligram a day, even entry-coated, is advisable. Chronic use, understand chronic use, 2-3 days if you can give, that is okay, watch the patient. But chronic use is not advisable. You have to avoid. And we know that you can stop cardioprotective aspirin for 5 days without any much damage because it has a half-life, long half-life. So if I'm giving some NSAID, which is a potent one, for 5 days, I can tell the patient to stop aspirin for 5 days and then restart again. FDA, this is American FDA, recommends taking ibuprofen at least 8 hours before or 30 minutes after aspirin to reduce the likelihood of an interaction. So again, I have been talking in various other webinars that when we write a prescription, we should write time, should not write 1, 2, 3 or after breakfast, lunch and dinner. So ibuprofen 8 hours before or 30 minutes after a cardioprotective aspirin. Then antidepressant. Selective serotonin reuptake inhibitors with NSAID is possible because they can affect platelets. Furthermore, there is a reaction possible considering that some SSRI inhibit an enzyme CYP2C9. We don't have to remember. This enzyme is involved in ibuprofen and diclofenac, and it is also involved in SSRI, so you may get an interaction. Now see, I learned all this today when I was preparing for this talk. Even I would never think twice when combining an antidepressant with an NSAID. 2 of the studies concluded that the risk ratio for an upper GI bleeding after giving 2 drugs together was greater than additive risk of 1 drug alone. When combined with another NSAID, see, some doctors have a habit of writing 2 NSAIDs or even low-dose aspirin. Remember, aspirin is an NSAID, it's a salicylate. So giving any other NSAID with that is also combining. Or with a steroid, you give diclofenac and you give steroid, increases the risk of GI ulceration or bleeding. If the patient is a bipolar disease and is on lithium, lithium clearance may be decreased by indomethacin, piroxicam and diclofenac. If the patient is on methotrexate for rheumatoid arthritis or psoriasis, then it may be displaced from his binding protein sites by NSAIDs used concurrently. And if a patient has pain, we always use. So we have to make sure that it is relevant. Now, if it is a normal kidney function, our 7.5 or 10 milligram twice a week is not relevant if the kidney functions are normal. That is why people on methotrexate low dose must have a creatinine every month. Renal failure and hyperkalemia. Hyperkalemia always occurs in renal failure. Have been reported in patients receiving triamterene and indomethacin. Triamterene is a diuretic. Alcohol, of course, because it irritates the gastric mucosa. So that irritation and NSAID irritation can work together. Alcohol alone also can favor GI bleeding when consumed in large quantity or binge quantity or without eating together. So with NSAIDs, the risk multiplies. Regular or heavy drinking of alcohol while taking NSAID may increase the risk of GI damage or bleeding. Very common if you have a patient who's alcoholic. People who drink a lot, next morning they have a headache. They take 300 milligram aspirin, 2 tablets, they dissolve in water and then they take. Very high risk of GI bleeding. NSAIDs are widely used due to their anti-inflammatory, analgesic, antipyretic, or antithrombotic effect, our low-dose aspirin. The safety profile of an NSAID remains positive when used in low doses for temporary relief of pain or fever. Elderly patient or in those with GI or cardiovascular risk factors, more caution is required to avoid complications further. Patients chronically treated with ACE inhibitors, hydrochlorothiazide, spironolactone or aspirin should be informed about risk of NSAID administration. We should be careful when giving in these patients. Now, I'll give few conditions where which NSAIDs work better. Etoricoxib 60 mg per day and diclofenac 150 per day seem to be the most effective oral NSAID for pain relief for and better range of movement in osteoarthritis, and does not mean both together, either one. However, they are not appropriate for patients with comorbidities, either a kidney disease or a cardiovascular disease or a liver disease, because there is a risk of adverse events. Topical diclofenac, now this is a research paper, 70 to 81 milligram per day seems to be effective and generally safer because of no systemic exposure, less chances of GI effect, and should be considered as first-line pharmacological treatment for osteoarthritis knee. This picture I will share with on Telegram group. GI toxicity least is ibuprofen as compared to aspirin, diclofenac, naproxen, indomethacin, piroxicam, ketoprofen keep worsening. And Cox2 selectivity is ibuprofen at this level, mid-level. So you can use this while prescribing these drugs. How do you reduce GI risk? Prescribe NSAIDs only to patients who do not respond to paracetamol. Select NSAIDs with lowest GI toxicity. Prescribe lowest possible dose for shortest duration of time. Coming of Tramadol, because we normally use a lot of Tramadol in like patients of CRF. Tramadol is not an NSAID. It's an opioid pain medication. I'm just talking today because we should not think it's another safe NSAID. Used to treat moderate to moderately severe pain. Like other opioids, selectively binds to different opioid receptors in the brain. It does not reverse its course completely after administration of naloxone. If a patient has opioid toxicity, you can give naloxone and patient will get better. But with Tramadol toxicity, naloxone will not help. Along with partial agonist activity on opioid receptor, it also inhibits the reuptake of serotonin and norepinephrine. So again, be cautious in giving with antidepressants. When taken orally in an immediate release form, not extended release, not sustained release, the onset of pain relief usually begins within an hour. Should not be used in combination with MAO inhibitors. Of course, we don't use much MAO inhibitors in India. And should be used in combination with other serotonergic drugs like triptan, if being given for migraine, certain tricyclic antidepressants, and lithium, because it leads to serotonin syndrome. And what is serotonin syndrome? Is a serious drug reaction causing agitation or restlessness, insomnia, confusion, rapid heart rate, and high blood pressure. Dilated pupils, loss of muscle coordination. So may not remember all this, but be cautious in giving a patient who's taking either triptan or tricyclic antidepressants and lithium. Nimesulide is another drug which is used for fever and mild pain. It's a relatively Cox2 selective with both analgesic and antipyretic properties. Approved indications are acute pain, symptomatic treatment of osteoarthritis and primary dysmenorrhea in patients about 12 years of age. It has been banned in several countries because of the risk of liver toxicity. What is chronic use of NSAID? Chronic use is defined as chronic if these are taken more than 3 times a week for more than 3 months. World Health Organization has an ICD code list, and World Health Organization has identified chronic use as a health problem. ICD-10 code Z79.1. For long-term use of NSAID, medical classification, it affects health status and causes more interaction with health services. Avoid chronic use of NSAID. Few utility drugs, osteoarthritis, they are the first choice. 50% patients report they are better, whichever NSAIDs used. So it is your choice, your comfort, and patient's coexisting complaint. Select as per patient profile. Rheumatoid arthritis may be used for pain inflammation, but will not alter disease progression. You need to use disease-modifying drugs like methotrexate, etc. Only symptomatic relief. Select as per patient profile. Shortest duration possible. Ankylosing spondylitis, again, NSAIDs are first choice. All are equally effective with exercises. Select as per patient profile. Migraine. Ibuprofen, aspirin, and naproxen are preferred first-line drugs. Mild to moderate, acute and chronic pain. They may be prescribed alone or with some opioid analgesic. May be useful in chronic musculoskeletal pain due to anti-inflammatory properties. Fibromyalgia, this is off-label. It is not recommended, but some patients with severe symptoms that interfere with sleep may be given NSAIDs. And in dysmenorrhea, a study says diclofenac reduced pain on a visual analog 100-point scale more than meloxicam. Phenoprofen reduced pain intensity more than aspirin. Etoricoxib was more likely to achieve pain relief than ibuprofen. Naproxen reduced pain more than ibuprofen, or celecoxib was more likely to achieve pain relief than ketoprofen. So our naproxen is a very good drug for even dysmenorias. This table also I will share on Telegram. This is all properties and comparative study of NSAIDs. Thank you. Thank you very much. Safe NSAIDs and antihypertensive, I will say give paracetamol only. Don't give anything else. I have to leave today, so any questions, please write. I will answer on Telegram.